Hello, hi, good morning everyone. Thanks very much for those brilliant presentations. Yeah, as a 55-year-old woman living with HIV, I'm like determined not to go down that route of Gladys. So these are my disclosures, and the money goes to NAM AIDS Map, not to me. Just thought I'd add that as well. So I was diagnosed with HIV about 26 years ago through a routine immigration test. I just got married to my second ex-husband. I've had 3 ex-husbands so far, always on the lookout for ex-husband number 4. I haven't actually dated any pharmacists or nurses yet, so yeah. See you all later. So when I was diagnosed, it came as a huge shock to me. I knew very little about HIV beyond the tombstones and iceberg campaigns. And I was told at the time by the immigration doctor that I had about 7 years to live. Obviously, that was nonsense. So doctors do get things wrong. Sorry, Laura. Sorry, Vanessa. But yeah, so sometimes you guys, you occasionally mess up. But my way of coping was to find out everything that I could about HIV, and I got support from NAM AIDS Map, where I work now. So I would say that I am pretty much very well informed about HIV. I'm on the board of the global network of HIV. Quite a lot of my work is looking at data, so you would think that I should be a model patient. And I was having a chat to Bruce Richmond, who many of you may know is an internationally renowned person living with HIV. Again, you would think that he should be a model patient. But when we were chatting, we actually both admitted to each other that over this year, we've been getting our medication by just rocking up for an emergency supply. We have both been getting to the point where we're down to our last pill. And I think that's the case for many of us. There's so much going on in our lives that it's really hard to focus on our own care. And I actually, for the first time in ages, I kept a track of the hours that I was working, and I realised that I'd actually worked 8 days over my normal working hours just on my regular day job, on top of everything else, of the other commitments that I have. And I think that's very much the case for many of us. And my doctor is very long-suffering. She actually called me earlier this week about like 8 p.m. because I was on her naughty list of people to actually to catch up with. And there was very much a discussion about things that needed to change about how I was living my life, and potentially how the kind of care that I was getting, and the potential to changing my medication. So you may be seeing patients and thinking that everything is fine, but the reality can be very different. I would say that relationships between people living with HIV and our healthcare professionals is really unique. I think, I don't know of any other disease areas where there is such close partnership. And in terms of the people living with HIV that I speak to, generally attitudes towards HIV healthcare professionals is really, really positive. People really value the time that you spend with us, the care, the compassion, which can be really different to the other healthcare professionals that we see. But I would like to emphasize that in terms of you caring for us, I think it very much you need to recognize that it needs to be a partnership. And the most effective thing that you can be doing is to help us to be more empowered to make informed decisions. So we work together rather than a paternalistic type of approach. And people often highlight as well is that even though people really value their time with with their HIV healthcare professionals, there are still issues in terms of feeling that there isn't enough time, that when we raise our concerns, we may not be believed. And also, it's really important to recognise when you consider patients that we are not a monolith, that we lead extraordinarily different lives, and it's very important that you recognise this and that our care is person-centred. And for many people living with HIV is just a really small part of our lives. For the majority of people, it's the intersecting forms of stigma, discrimination and disadvantage that's devastating people's lives. And if you think about the situation now that we're in, for many people, if you consider someone, say, who is a migrant living with HIV, who has no recourse to public funds, who doesn't have enough money for food for themselves and for their children, of course, their HIV care is going to drop down to a really low level of priority. And it can be really, really difficult juggling all of these different issues. And we think about some of these challenges as like, okay, they're not really to do with health. But so often the issues that people face, they are impacting on our health. The chronic stress that many of us are under, the lack of sleep that we're getting, they're all impacting in terms of inflammation going up and our health getting worse, and the more likelihood of us developing comorbidities. And in relation to HIV care, I know that we've been I'm based in the UK, but in terms of my role in the global network of people living with HIV, I hear about international concerns. And for many people, HIV-related stigma continues to be a significant barrier to accessing care. I was speaking to a friend who lives in Kenya, and he was saying that where he lives, being gay is potentially criminalised. One of his friends was actually murdered. My friend was attacked, and when he called the police, they harassed him and were supporting his attackers. And so for many people living in regions like that, the reality is actually going and getting HIV care can be putting their lives at risk. Being seen with medication could be putting their lives at risk. And just generally in terms of HIV-related stigma, we've come a long way, but it continues to be a significant barrier for many people. It's the stigma that we get from society, it's the stigma that we have from family and so-called friends and employers, and it's also the self-stigma. And the self-stigma that people experience, it's understandable when there's a load of stigma attacking people from elsewhere. And another issue that comes up is that sometimes people feel that there's just too much of a focus on our blood results, that we go in and we're told, yeah, everything's fine, your CD4 count's fine, your viral load is undetectable, thanks very much, see you in 6 months. When the reality is, it's all of the other problems that people are facing and experiencing that is the real challenge to our health. And COVID shone a light on health inequalities. But the reality is, with the move to virtual care, that doesn't suit everyone. That can be really difficult. I was speaking to someone who is an asylum seeker. They're living in a house with other people who don't know about their HIV status. They try to have a consultation with their doctor, and they were on the phone, and then someone came in and said, "Who are you speaking to?" They moved into their kitchen. There was someone there. They went into the bathroom that they share with 10 people. Someone was knocking on their door. It can be really difficult. And also with virtual care, it's the other issues that can be harder to discuss. It's the and another thing. I know for me, I was diagnosed with breast cancer 10 years ago. And it was actually my HIV doctor who saved my life, because I was initially told it was just a cyst. But then when I went back and saw her 6 months later, as I was going through the door, she said, "Oh, is there anything else?" And I said, "Oh, yeah, everything's fine. I've just got a bit of a rash around where they did the biopsy." And she said, "Oh, no, that's not good. You've got to go back." And I was like, no, they said it was just a cyst. But, she nagged me in the way that many of you doctors can be quite naggy. So thank you for that. And I went back, and it was found that I actually had triple negative breast cancer. That's one of the most aggressive. And the tumour was 5 centimetres all around. So if it wasn't for the time, if it wasn't for that and another thing that I had with my doctor, I probably wouldn't be alive today. And also, for many people, virtual care can be great, because for many of us, it's the travel to the clinic that can be a problem. It's the childcare in relation to that. And I remember back in the old days that HIV doctors and people working and healthcare professionals would help us with everything. And it can be a bit of a problem for people in that, essentially, we appreciate that you can only prescribe HIV medications, but when our challenges are other areas, it can be really, really difficult. But I do think that there's a role for HIV healthcare professionals to act as a central figure and coordinate our care, because often it can be really, really difficult. And as has been pointed out, very often it's the other health problems that people are facing that are a huge problem. And people are really worried about aging as well. Someone was speaking to me about their absolute terror about the kind of care that they would get if they were to go into a care home. And it can be really, really difficult navigating the health service, particularly in relation to primary care. I was running a session at Food Chain yesterday, and I spoke to some of the people there who often are facing some of the biggest barriers in a huge variety of ways in terms of their health. And it was the number one thing that came up, a problem that people were facing, was the issue around GPs, the constant ping-ponging back to the HIV clinic, then being sent back to the GP, and then if we have other health conditions, we're sent there, who then send us back. And it is exhausting. And very often people are feeling like, oh, well, I just can't cope, because it is too much. And then also it's just the impact of the pill burden. Thank you for highlighting about all the pills that someone can take. And when you think about, okay, yeah, HIV, for some of us it's just one pill once a day, but when people are taking a huge handful of pills, it can be really, really difficult. And just in terms of menopause, I've got a photo of me with 2 other menopausal women living with HIV, Sylvia Petretti and Angelina Namiba. And I would say that, we're coping okay with our menopause, but we know that women with HIV may experience worse symptoms of the menopause and may get it a little bit earlier. And when we think about menopause, we think about hot flushes and mood swings, but for many people, there's so many other issues like night sweats and hair loss and repeat urinary tract infections and not being able to sleep. And the PRIME study led by Dr. Shima Tariq and colleagues at UCL found that women with HIV are more likely to have low sexual function than negative women. And when we think about sex, there's a stigma around living with HIV and having sex, and there's a stigma around being older and having sex. So often the notion of sexual pleasure is ignored. And also, the PRIME study found health inequalities in relation to women from racially minoritized communities who were going through the menopause, who were more likely to have a degree, but also more likely to be living in poverty. Black women were found to be more likely to be experiencing emotional distress, but less likely to be offered any support. And these health inequalities aren't anything new. They're not unique to HIV. Health inequalities have been devastating the lives of people of colour for generations across disease areas. We know that Black women are 4 times more likely to die in pregnancy. And data came out earlier this month that found that Black babies are 3 times more likely to die in the UK than white babies. And that statistic really shook me up. Even though I'm hearing about this day in, day out, I co-host with Vanessa Rapia, Health and Power, a broadcast on health inequalities. And initially, we thought that we might be able to focus on, on a condition and the health inequalities around that. But the reality is that so often it's intersecting. And many of the people of colour that I speak to living with HIV are saying, why bother? Why raise the concerns to any doctors? Because no one's going to believe me. I've seen it before. Nothing's going to happen. And we saw that in COVID, and we're continuing to see it. And even though people may be getting fantastic care from their HIV clinicians, but if they faced racism in healthcare settings, it's understandable that people aren't going to be trusting. And in terms of, I had a chat to some people living with HIV in terms of hopes for the future, and people are excited about new technologies, particularly around, if we can only go get treatment twice a year. And people really hope for stigma-free care. Even today, people with HIV are more likely to experience stigma in healthcare settings than anywhere else, which can be a huge barrier to accessing care. And it's desperate that we end health inequalities. We just can't focus on HIV in isolation. We need to look at all of the wider health inequalities. And peer support is crucially important. And we'd like to see it in all clinics. And we'd like our care to be joined up to end this constant ping-ponging around. And I know it's a long way away, but people are also excited about cure. And I have to say as well, is that one of the most empowering things for people living with HIV is information. We are not passive, voiceless victims. Women with HIV and people of colour living with HIV are desperate for clear, accurate and reliable information, and not to be patronised. So information can be extraordinarily important. These are just some of the things that we do in NAM AIDS Map, like our website, like the broadcasts that we're doing, and the booklets. I know that many of you do have access to it. And we're not going to be able to reach the targets, the 2030 targets, until we end inequalities for all people living with HIV, regardless of where they live and who they love. Thank you very much.